welcome you to our special celebration in honor of Nurses Week and the celebration of nurses and midwives. This is the 200th anniversary of Florence Nightingale's birthday. This is a very, very special celebration of nurses. I want to welcome all of you. I am the Dean of the School of Nursing, and today we have a chance to hear from a number of the members of our community. They include students, faculty, and our alumni who are working in the UC system. Our first speaker today is Dr. Mary Foley, a faculty member who directs our master's entry program. Carolina Noya, a faculty member in the Family Nurse Practitioner program. Taylor Cufaro, I've neglected to say Mary's pronouns are she, her, and hers. Carolina's pronouns are she, her, and hers. Taylor Cufaro, who is a student who came into our MEPN program and has progressed, has very interesting work to tell you about today. Taylor's pronouns are they, them, and their. Jerry John Neuter, who is a faculty member in family healthcare. His pronouns are he, him, and his. Sasha Binford. Sasha is a graduate of our PhD program who's now working as a clinical specialist in the health system. And Sasha's pronouns are she, her, and hers. And Orlando Harris, who is a faculty member in community health systems. His pronouns are he, his, and his. I want to thank you all who might be representing some of our event sponsors, clearly sponsored by the School of Nursing, also our Associated Students Association of the School of Nursing, our departments, our health department, and Sigma Theta Tau, and of course our Alumni Association. And I know I can see this on the screen that there are some of you from the Alumni Association who are here with us today. Thank you all for your participation. I want to give special thanks to organizers of this event. The brainchild came from Pat Sparacino and Charlene Harrington, has continued to work tirelessly with our participants and also a coach we brought on to try to help us make sure that these were nice, crisp, TED-type talks for you today. Angel Pong and Hannah Zhang have also been very helpful in working with this group. Again, my thanks to all of our event sponsors. We're going to begin with a talk from Mary Foley, who will explain to us why we are inspired by Florence Nightingale. Each of these talks will seed into the next. And at the end of the time that our presenters have shared with their formal presentations with you, we'll have an opportunity for Q&A. In the meantime, some of you who are familiar with this format may realize that there is an opportunity to begin to create questions. For those of you who are less familiar, if you go down to the low bar, the bottom bar on your screen, and you hover over the middle of the screen, you'll see chat. And you can actually click on chat and enter a question that will show up for us to answer as we complete the talks. Our chat moderator today is Peter Weber, who at the conclusion will help us to identify the questions that have been asked. He'll call them out and we will allow our participants to respond to the various questions that you have. Welcome once again, and with no further ado, Mary Foley, addressing.
Thank you, Dean Gillis. I really appreciate the opportunity to be here today. I am representing the school and the Sigma Theta Tau chapter, Alpha Eta, and it's an honor to talk to you on the day before the start of the Florence Nightingale International Year of the Nurse and Midwife celebration. It was recognized by the World Health Organization that this was the year to celebrate the 200th anniversary of Florence Nightingale's birthday. And so they declared, and because of the role of midwives internationally, globally, a much significant impact in the delivery of primary care as well as in the US, they declared it the International Year of the Nurse and the Midwife. Why? Florence Nightingale is just one individual who has been given credit for having probably written the most about early nursing and endowed us with certain knowledge and lessons, common sense and insight, and the origin of some of our very basic science and statistics. She was a very well-off person in England, in a Victorian family, probably the least likely person to find herself leading a group of individuals in a battlefield to care for injured soldiers, but that's indeed what she did. She went to the Crimea at the request of a personal friend in charge of the War Department. The death rate prior to her arrival was just abysmal, and it was not from war wounds, it was from the death after the wounds, 43%, and they think that was a low estimate. After her work and her very amazing introduction of the basics, remember she didn't have IVs or antibiotics or any of that, kitchens, laundry, recreation areas, waste control, cleaning protocols, sunshine. And she was a statistician at heart and really created this pre-computer, where we now have a historical record of those activities, but also very importantly, she led nursing down the path of continuing to document what it is that we do and how we make differences everywhere. And those are just a few of those great slides. And so she really was able to institute some of the basics, the common sense essentials. This is an example of basic infection prevention. This is a hospital ward in Scutari after Florence Nightingale arrived, and you'll notice sunshine, clean bedding, one soldier per bed, and probably some good food somewhere in there, which she actually had to take away from the officers because she recognized the value of nutrition and cleanliness, hygiene, and care. And so she was the founder of modern nursing, a visionary. She worked on the environment. She went back to England, worked on clean water and clean air in London. She used data and she documented it. She was one of the first women ever inducted into the College of Statisticians. She started the first formal school of nursing, though others had certainly developed the skill set and the knowledge to pass on how to care for others. And she was really a creator of some of the care for soldiers early on and the veterans of the wars in England. She was recognized, in fact, the Smithsonian Magazine in the spring did a great issue on the defiance of Florence Nightingale. And so it's really nice to see how this started the celebration this spring. However, we had no idea what kind of spring we'd be having or what kind of year the Year of the Nurse would become. And in fact, the World Health Organization and ICN are going to carry the Year of the Nurse into next year as well, because this is not the year for parties. And so this is the year for the incredible hard work of just a few of these nurses that I'm showing you here. And so stay home, wash your hands, and we will be able to enjoy days like this, our beautiful Golden Gate, our beautiful fields. And thank you so much to everyone who is on the front lines, and certainly to the students and other health leaders on this program today. It's an honor to be part of this. Thank you. Oh, and I'm sorry, I'm introducing Carolina Noyo is the next speaker. Thank you.
Hello, I'm Carolina Noya. I'm an associate clinical professor in the School of Nursing, and I am honored to be here. Today, I'm going to be talking about building community and resilience in diabetes group care. My goal today is to inspire you to disrupt the status quo. Can you believe that nationwide, less than 1 out of 5 people living with diabetes are achieving diabetes clinical goals? As many of you know, structural issues contribute greatly to this problem. But today, I want to focus on the interpersonal interaction that shape patient care. So I want you to ponder this question. Is it possible that patterns of dominance in our clinical encounters are part of the problem? I believe they are, but I also believe we are capable of creating a more equitable space with our patients. So today I'm going to share one model of care that tries to disrupt and redistribute power in a clinical setting. So I want to share a story about a patient. Her name is Ms. Rivas. She has been a patient at our clinic for many years and has struggled to manage her diabetes. Medical providers have left a trail of comments in her chart, which included, and I quote, non-compliant, no-show, resistant, unmotivated, and a poor communicator, just to name a few. When she started attending the shared medical appointment program at our community clinic, her hemoglobin A1C was 12%. That is an average blood glucose of 298. Now, we know that most healthcare providers working in poor communities do not represent the population they serve. And many of us struggle to understand the nuances of managing a chronic condition in a social context that is filled with structural barriers. So how can we support someone like Ms. Rivas? Now, I want you to imagine Ms. Rivas entering a shared medical appointment where she's going to meet 12 other people like her. They're also living with diabetes, share her background, language, and social context. In this space, she will spend 2 hours surrounded by peers who can relate to her experience, who can problem solve and understand her struggle, who would not judge her for rationing her insulin because she's low on money that month, but instead will give her advice and strategy to cope with this burden. Shared medical appointments is a space for a shift in power, a shift from those who have been granted power to those with the least autonomy. In this space, patients are inspired, they are seen, understood, and they are heard. This picture that you're seeing here is of a group in Chiapas, Mexico. Patients decided on the spot that they wanted to dance and leave aside what was planned for that day during that session. They wanted to dance. So what did we do? We danced. This is what I mean by disrupting structures of dominance. The patients, not us, are in charge. So back to Ms. Rivas, in the 2 years that she attended the SMA program, I would learn more about her struggle with domestic violence, food insecurity, and profound financial stress. Maria slowly opened up as if sheltered by the group and was able to open up and be vulnerable with us. She became the leader in our group. And check this out, this is a true story. She designed an exercise program where she used cans of beans for resistance training that she would do while watching her favorite novela. Her A1C dropped to 6.9% 1 year after starting the program. That's an average blood glucose of 151 compared to 298. Now, switching gears, let me just briefly share my research as evidence of this model. 2 studies of this model, one in the Central Coast and one in the Central Valley of California, have shown that participants in the SMA model had an additional drop of 0.7 to 0.8% in A1C compared to the control group at 6 months. This is comparable to a drop with a very expensive new medication. I really do wish I had a patent I could sell to pharma. But to me, really, the most important outcome is giving patients the voice and space they deserve and need to successfully manage their condition, and best of all, to do it in community rather than isolation. Out of this process comes this powerful sense of well-being that is defined as a collective experience, informed by wisdom, the wisdom of the patient's lived experiences. And as providers, we really are given this privilege and gift of being part of this communal experience. In this space, as providers, we can shed preconceived notions about our patients. We can shed the belief that we know best. We can learn to listen to their voices and become their allies. We can support their effort to heal despite all the structural barriers that restrict them. And I just want to share one more quote from Mr. Sosa. He's a patient from Chiapas, part of that group that I showed you earlier. And these are his own words, and I quote, "Here, we give each other life. Why? because no one feels left out or discriminated against. No one tells you, hey, you, don't do this. No, here everything is up to you. So as I'm wrapping up, I want to leave you with a challenge. I want to challenge each of you to shake things up, to disrupt those structures of dominance within your medical encounters. I want to challenge you to create a space where the patient's voice and knowledge is at the center, and where you as a healthcare provider are there to listen and learn, not the other way around. Thank you so much for listening, and I'm going to leave you now with our next speaker, Taylor Cufaro.
Hi, all. My name is Taylor Cufaro, and I am one of the co-founders and current co-director of UCSF Nursing. The theme for today's event to kick off National Nurses Week is, what would Florence do? And when I think about what Florence would do, I think about what she and so many of the grandparents of nursing did do. They nursed. Of course, I think of Florence Nightingale, credited with founding of modern nursing, but I also think of Lillian Wald, Mary Brewster, and the Henry Street nurses, who realized wellness was not specific to the individual, but to entire communities. Rather than continuing down the established path, the Henry Street nurses left behind their normal operation, moved to a house in New York City's Lower East Side, and provided nursing care that included economic and social support for marginalized communities. They also built a killer playground in the backyard. I think of Sarah Gomez Erlock, of Mabel Stopers, of Leonor Villegas de Magnon, and the women of La Cruz Blanca. And if you don't know these women and their contributions to nursing, please do look them up. When my co-founders and I considered what we could do about the ever-increasing houselessness and health disparity for unhoused folks in the Bay Area, the answer was clear. We could nurse. UCSF Street Nursing was officially founded in August 2018 by myself, Megan Grant, Michaela Lambert, Tessa Rubin, and Janelle Silvis, and we've recently been joined by Katie Machado. Together, we represent midwifery, women's health, pediatrics, family, and adult gerontology nursing practice. Each of us bring to nursing many years working on the streets with a collective 10,000 plus hours of street-based service provision prior to entering the field of nursing. You know, initially we were ready to charge the city, backpacks loaded, brand new nursing skills, bright eyes, bushy tails, sensible shoes. We quickly talked ourselves down and through months of needs assessment settled into an incredible partnership with Lava May, an organization that provides mobile showers 6 days a week in both San Francisco and Oakland. Lava May is our ideal partner in that they make a point to really know all of their guests, many of whom they see multiple times a week. Okay, so we had the right idea, the right partner, it was go time. On April 1st, 2019, we pulled my Subaru up behind Lava May's 3-stall shower trailer outside the San Francisco Library's main branch. Stethoscopes in hand, we were ready to nurse. And man, did we nurse the hell out of the one person who was willing to talk to us that day. Well, in the 9 months that followed that first shift, we set up shop 4 hours every other Tuesday. We began to build trust and we proved our reliability. We went from seeing 1 to 2 patients a shift to 20. And recent funding has allowed us to quadruple our care provision, doubling our hours here in San Francisco and adding a weekly clinic in Oakland. And since said funding kicked in, we've been able to see as many as 150 clients a month. In these encounters, we provide basic nursing care to support the overall wellness of our clients. Let's have a quick thought experiment. Okay, so you've got a bug bite on your calf, annoying. Naturally, you scratch it. Unfortunately, you seem to have developed a bit of a skin infection and you end up in the ED. You're discharged with oral antibiotics and some wound care that is really easily managed at home. Bummer, but easy enough. You go to the pharmacy and pick up your meds. While you're there, you buy saline, gauze, tape. You YouTube how to do a dressing change, and you seamlessly add wound care into your morning routine. Well, rather quickly, your problem is resolved. Now, what if I were to take away the ability to buy supplies, the YouTube, or even the shower? It would be extremely difficult to take care of that wound. It may fester. You may end up back in the ED requiring IV antibiotics and admission to the hospital. And this is where street nursing comes in. You may be without the supplies and the YouTube, but you regularly shower with Lava May. Oh, and there we are. We can teach you how to change your dressing, and we can give you a week's worth of supplies to carry you through until we see you next. We can talk to you about the side effects of your antibiotics and reinforce the importance of finishing the bottle. We can tell you if it's not healing as expected and refer you to the proper level of care. And truly, wound care is one of the more common services we provide, along with health education, blood pressure checks, and referrals to primary and specialty care. Most importantly, though, we provide a listening ear. Without the forced time limits of traditional care, we're able to spend as much time as we need with our clients. In many ways, I really consider us nursing ambassadors. We believe if we can be a positive point of contact within the healthcare system, that our clients may feel safer engaging further in their own care. Our service offerings are extremely modest, but as most nurses know, they can be hugely impactful. But what about COVID? Yes, what about COVID? Well, the flexibility of providing care outside the bounds of a traditional clinic has really shined with COVID, which has dramatically affected the Bay Area's unhoused community. When San Francisco and Oakland banned group gatherings, our regular clinic setup was no longer feasible. In response, we took a page from the Henry Street nurses. We walked away from our normal gigs and asked our clients what we should do. As more and more people found themselves living on the street, the needs were simple and obvious. Tents, sleeping bags, masks, hygiene supplies, food and water. In my decade of providing services on the streets in San Francisco, I have never been asked for food as much as we have been since COVID hit, and I have never experienced a true need for drinking water. We now do twice weekly outreach shifts to hand out camping gear, hygiene kits, food, and of course, water. We continue to turn away twice as many people as we give supplies to and drive past 3 times as many encampments as we can service. So, where is UCSF Street Nursing headed? Obviously, we'll continue with our COVID response. And once we're done sheltering in place, we're excited to be collaborating with UCSF's Deliver Van to be able to provide Hep C testing and treatment out on the streets to our San Francisco clients. And we've just this week finalized our collaboration with the UCSF Emergency Department to provide supportive nursing care to patients who frequently use the ED. The Pipe Dream, a clinical specialty track focused on care provision for unhoused, marginally housed communities so that all UCSF trained nurses can follow in the footsteps of the badass nurses who came before us. As I reflect on Nurses Week, I hope that all of us who've added letters beyond RN, and I still have a few I would like to add, I hope we stay connected to the legacy that came before us, to the ideals of those who created the nursing model, that we bring our foundation in nursing into every project we do, into the research we conduct, and into the care we provide. So, what would Florence do? She would donate her camping gear by emailing taylor.cafaro@ucsf.edu. Thank you. And now I will turn it over to Jerry Nutor.
Hello. Good afternoon, everyone. My name is Jerry John Nuto, and I'm assistant professor here in the School of Nursing. Thank you for joining us this afternoon. And the title of my talk today is People Living with HIV, COVID-19 Lockdown, and Medication Adherence. Well, we are in the middle of crisis, a crisis that our generation have never seen before. And this is the COVID-19 pandemic. Have you ever paused to ask about how people are struggling with chronic diseases such as HIV are dealing with these chronic diseases, especially in low-income countries and also among the low-income population in developed countries? Well, before even the COVID-19 pandemic that hit both the poor and rich countries and have forced them to actually go into lockdown, there has been a problem of access to water and sanitation across the globe. According to the World Health Organization, more than 785 million people in the world do not have access to clean water. And over 2 billion people in the world do not have access to adequate sanitation. And 10% of the global population practice open defecation. Well, UNICEF also reports that in low-income countries, averagely, women and girls spend more than 6 hours a day in search of water for domestic use. Majority of these people, as you can see on the map, are in the global south. That is mostly in sub-Saharan Africa. Well, the same way that domestic access to water is a problem, that is how nurses and midwives and other health workers across the developing parts of the world struggle to have access to water in order to take care of their patients. Well, as I think about this COVID-19 pandemic and all that is happening, it makes me think about my research. My research focuses on understanding how access to water, toilet, and other household resources influence adherence to HIV medication among pregnant and breastfeeding mothers, especially in low-income countries. In my recent study in Zambia, I found that women who have access to toilets in their home were more likely to adhere to the HIV medication compared to women who do not have access to toilets in their home. This result was true for water access as well. Now, as we may know, the common side effects of HIV medication or antiretroviral treatment are diarrhea, vomiting, and nausea. For that matter, people who do not have access to this water, kind of household resources such as water, toilet, and others are more likely going to skip taking their medication in order to avoid the side effects. Well, that is how the patients who are the participants in my study are struggling to actually survive in order to be able to continue taking their medication and adhere to the treatment. Now, let me paint the picture of the current situation with the same research participant having to deal with the COVID-19 lockdown in this current situation. As we may have seen in the news outline or the news headline across the world, we have seen that a lot of people in both developed and developing countries are struggling with access to water, especially with the lockdown. How can people wash their hands if they don't have access to clean water? If they don't have access to toilet in order to practice the best hygiene? And also, how does the COVID-19 response look like with limited access to water? How about food and other things? These are all the headlines that we see around the world. And we see the government and others are taking their steps to be able to step up to the game and mitigate the situation. But how about the vulnerable, the HIV positive pregnant woman, the HIV positive breastfeeding mother who cannot be able to get out to where food and others, water and other resources are being shared? Well, let me take you, as I wrap up, to the title of today's theme or today's event. What will Florence do? Well, I think Florence would have done the same thing that all the awesome nurses are doing across the world in order to help provide the needed nursing care that our patients need at this time, especially those that are dealing also with chronic diseases that need to continue taking their medication. Florence, in her environmental theory, defined nursing as an art of utilizing the patient environment to assist his or her recovery. Well, in this theory, Florence came up with 5 key things. These are fresh air, pure water, efficient drainage, cleanliness or sanitation, and finally, light or direct sunlight. Well, this means that even in the 1800s, patients were struggling with structural barriers or structural violence that we are seeing in our current generation. That actually are barriers to patient recovery. Imagine how patients or how clients that do not have access to water and other things can take care of themselves in the midst of all the shortage and the midst of the lockdown. Well, that is why I focus on understanding how this can be able to help in order to be able to provide the needed nursing care to this population. Well, I realized that it is very important that as nurses, we conduct a comprehensive assessment or a holistic assessment of the patient environment in order to provide the needed nursing intervention to help our patient to be able to achieve recovery. That is very important. So as nurses, as we gather, as we ponder over Nurses Week, I want to share with you that continue to conduct your comprehensive assessment, both the patient home, their environment, and everything that will help them to be able to recover. As I end today's talk, I want to leave this quote from Florence with you. What nursing has to do is to put the patient in the best condition for nature to act upon him. Thank you so much for your attention. I now hand over to Sasha Binford to continue. Thank you.
Hi, I'm Sasha Binford, the UCSF Medical Center's inpatient geriatric clinical nurse specialist. And I'm honored to be a part of this celebration of Nurses Week with you all, and grateful for the opportunity to present on the topic of delirium and what I believe Florence Nightingale would do to help prevent and treat hospital-acquired delirium in today's healthcare climate. I'd like to invite you to imagine yourself waking up in an environment like this. It's dark. You can't visually make out enough to make sense of where you are at. You just know it's not a room you're familiar with. Is it nighttime? Or is it daytime? What is going on here? This was the confusion Mr. J experienced waking up in with little recollection of what had recently occurred. It wasn't, as you might have imagined, nighttime. In fact, it was midday and he was in the hospital. Mr. J had been admitted for pneumonia 2 days prior, but insisted he had been abducted and taken to a casino in Nevada where he was surrounded by constant lights and noises and people he didn't know, but who he was convinced were trying to force him to take drugs with the intention of making it hard for him to breathe. He stated that all he wanted to do was sleep, but he was afraid to let his guard down in this strange place, and no amount of reassurance from the friendly but completely unfamiliar nurse actually in his hospital room with him could convince him otherwise. And all he kept hearing her say was, "Here, take this, it will help you." Mr. J was experiencing delirium, a syndrome broadly defined as acute mental confusion. Delirium generally comes on suddenly and can fluctuate throughout the day and from day to day. Persons with delirium often experience difficulties with thinking clearly and acting rationally, sustaining attention and remembering recent events, being oriented to their environment, as well as experiencing vivid auditory or visual hallucinations like Mr. J did. Hospital-acquired delirium is serious and can increase a patient's length of stay, their risk for discharge to institutional care, as well as mortality. Delirium is distressing to patients and their family members, and it can have significant and potentially lasting effects, including risks for developing new onset cognitive impairment in the ensuing years. Delirium can be distressing for staff as well, often leading to their burnout. Delirium is complex with a combination of contributing risk factors and precipitating events, such as changes in the environment, like being in the hospital, sleep deprivation, as well as alterations in the normal sleep-wake cycle, and infection, like Mr. J's pneumonia, and much like what we are seeing today in presentations with the COVID-19 illness. Nationally, it is estimated that 1 in 4 hospitalized patients are at risk for developing delirium. Roughly 30% of these cases are preventable, however. Current evidence does not support the use of medications such as antipsychotics to prevent or treat delirium. In fact, evidence does show that these medications can increase the risks for mortality in some patients with delirium. So what would Florence do in a situation like Mr. J's? Well, I believe Florence would start by shedding some light on the situation, literally, and utilize the patient's own environment to facilitate their recovery. employing interventions like mobilizing Mr. J early and in his hospitalization and often throughout the daytimes, offering repeated opportunities to be and stay oriented, ensuring adequate nutrition and hydration, as well as sleep promotion during the nighttime, cognitive and social stimulation, and ensuring any needed sensory aids like glasses or hearing aids are available and in use. In fact, a multi-component non-pharmacological intervention bundle such as this has been shown to be effective and is recommended as first line for preventing as well as treating delirium. I also believe that Florence would use her data collection and analyses skills to study what is or is not currently happening in the care environment and with what frequency, to target where improvement efforts are needed, like getting the blinds up in the daytime or the lights off in the nighttime, in order to support establishing these interventions as part of the everyday workflow in the hospital for all patients, including Mr. J. But to also identify what the barriers are, like patient preferences, which is what Mr. J's nurse stated was the reason his blinds were down in the daytime, since he didn't sleep much the night before in the casino. This is the work we have been doing in the UCSF Medical Center's ACE, Acute Care for the Elderly Unit, where the delirium reduction non-pharmacologic care bundle was introduced as a standard of practice with the sunrise and turn down services to promote daytime wakefulness and nighttime sleep. And we have measured this bundled intervention against important metrics, such as the delirium rate, average length of stay, the use of safety attendants, as well as use of restraints. And we've seen a decline in each of these outcomes on the ACE unit since introducing the care bundle in early 2019. Environmental interventions don't always provide the quick fix to a problem like delirium that an acute care center generally aims for. And while they are shown to be effective, they really require all of us, nurses, providers, family, friend, visitors, and others in the care environment to do our part in making them happen as early and as often as possible during a hospital stay. And this is in order to best support our patients, like Mr. J, in being awake and engaged in the daytime and asleep in the nighttime to prevent or treat their delirium. And in a time like this, with our hospitalized patients experiencing significant isolation in their rooms, these kinds of interventions are that much more important, even if it's just a matter of getting the blinds up in the daytime to let the natural light in. Thank you for doing your part. Thank you. It's now my pleasure to hand off to Orlando Harris.
Thank you. Good afternoon, everyone. So the title of my talk is What Would Florence Do using research to advocate for the rights of sexual and gender minorities? I want to take us on a journey through the Caribbean, where I do most of my work. The Caribbean represents an archipelago of islands surrounded by the Caribbean Sea. For many people from Europe and North America, it is viewed as paradise. However, for many of its inhabitants, particularly those that are sexual and gender minorities, it is a mix of both pleasure, paradise, and pain. To illustrate this, let me tell you about a few of their stories. Now imagine growing up in a society, a Caribbean society, where your very existence is perceived to be an abomination. A society where you were taught at an early age that desires and intimacy between those of the same gender were not acceptable and could get you killed. As a result, you learn very early to keep those desires to yourself. For example, a client of mine named Mark said this: "I never knew what was happening to me. I thought it was just a phase. But when I realized how the society was at the age of 14, I couldn't express it. I mean, it does not work like that here. And though I had a good relationship with my mother, she would say that I can't be this way. It's ungodly, and you will go to hell. So I made the decision to keep it to myself." Next, imagine dreading attending school because your gender presentation does not align with society's definition of masculinity and femininity, which resulted in persistent bullying from your peers. Now, imagine your parents having to make that shocking decision of asking you to leave their home because members of the community threatened to destroy their property because you were perceived to be a gay or lesbian. What would you do? Where would you go? Do you stay and fight, or do you leave everything and everyone you love behind? Here's another example from a client of mine, Paul, who said this. It's very challenging being gay and having some form of feminine tendencies. Community members really don't accept me. At one point, the community forced my mother to turn against me, so I left her house at age 15. Imagine being denied a job or an apartment because of how you look or because your love looks differently than others in the society. What would your employment prospects look like? Where would you sleep? How do you provide for your basic needs? Imagine the impact on your mental health. You're a transgender woman living on the margins of society. And despite the discrimination and violence that you know you will encounter on the streets, you have decided that dressing in gender-affirming attire or living in your truth was worth it. You carry a weapon to protect yourself because someone always tries to mess with you. Now imagine spending your last few dollars for public transportation so that you can go to a clinic for services and being turned away because the security guard refused to let you in. They perceive your attire as inappropriate. The nurses turn their noses up at you and make derogatory comments about your appearance. You see them flipping through your chart while looking at you, whispering to each other. Instead of providing you with the care you need, they spend that time preaching about the gospel and why you should change your ways. Would you trust these people? Would you ever go back for care? These are the stories of the clients I have encountered as a clinician. I have heard providers refer to them as hostile, difficult, and ungrateful, all because they refused to accept the subpar care that was being provided by healthcare workers. These same individuals have been misdiagnosed and medicated for mental health conditions without any considerations for the decades of trauma that they had experienced prior to entering the clinic. I've shared some of their stories with you in hopes of arriving at the question that is at the heart of today's talk. What would Florence do? Well, what would other nurses like Mary Seacole, Susie King-Taylor, Mary Mahoney, Sojourner Truth, and Mabel Keaton-Stupers do? These were women of color who wanted to care for the sick, just like Florence. However, the only obstacle that stood in their way was the color of their skin. I think they would care about the rights of sexual and gender minorities the same way I do. I think they would care for the patient not as the sum of their individual parts, but as a whole, thriving within systems of oppression. Like these nurses, I think about my participants' stories whenever I plan research activities that involves them. I think about those unhoused individuals who cannot shelter in place the same way I could. I think about their circumstances and what led them to the streets in the first place. I think about the start of the hurricane season, which is right around the corner. While their social situation is not ideal, there is something present that we as advocates can build on. That is their sense of family and community. Mary Seacole once said, "I am not ashamed to confess that I love to be of service to those who need a woman's help. And wherever the need arises on distant shores, I ask no greater or higher privilege than to minister to it." Like her, as a nurse clinician, educator, and researcher, I am not ashamed to advocate for the rights and well-being of Caribbean sexual and gender minorities. I have traveled across the Caribbean for over a decade doing exactly that. Through those experiences, I've learned several things that I think that should be used as a guide to better serve the community. So I will leave you with 3 of those things. The first, we must always meet communities where they are. The goal is to never try to act as a savior, but instead to work collaboratively with communities as partners in order to meet shared goals. 2, in order to build trust with our patients, we must take the opportunity to learn from them and provide them with the tools necessary to safeguard their own self-determination. And finally, 3, we must also understand that our patients are really good at assessing our intentions. We must acknowledge that we provide care through systems that are rooted in hegemony and in other forms of oppression. Therefore, it is vital that we provide care through the lens of cultural humility. Thank you, everyone. At this time, I would like to begin the question and answer portion before concluding today's talk. Again, as a reminder, please utilize the chat box to post your questions.
Thank you all very much. This is Catherine Gillis once again, and I'm going to invite Peter Weber to begin to indicate what questions we might have for our presenters today.
Okay, thank you, Dean Gillis. So the first question that we have is for Carolina. The question is, how were you able to get this group together? I assume they are hardworking people with not much leisure time.
Yeah, so it depends on the setting, right? Like in the United States, these were appointments that were scheduled throughout the day, sometimes in the morning. Sometimes the morning was a better time for women, but we also offered a time in the evening. So we held an evening group for those who were working and needed that adaptation. In Mexico, they are part of their regular healthcare. So they offered the group once a month at a time that was convenient for participants. So as everything, you know, you adapt to the context, and it varied quite a bit.
Okay, another question for you, Carolina. Yeah. I love the shared medical appointment model and dynamic of peer support, especially with something so much as making lifestyle dietary modifications. Was there a structure with a didactic curriculum during visit? After the 2-year period, did members remain in contact?
Okay, so my model does not follow a structured curriculum. The curriculum is co-created with the patients. So every week the group chose what topic they wanted to review the following session. And they also gave us ideas about how they wanted that information presented. So it was co-created. Of course, we used the ADA guidelines as a backdrop, making sure that we were addressing those needs. But it was essentially, the agenda was set by patients. And then every attempt, of course, was made to assure that the material was culturally appropriate and also accessible for people with low health literacy. And the question about what happened with patients, again, that varied by context. In Chiapas, this model has replaced their usual primary care for diabetes. So this is how they now receive their care for diabetes. In the clinics, in the FQHCs in California, again, it varied by clinic. Some clinics had it once a month. Some clinics had a period of time where it was more intense, and then it slowly, you know, it changed over time. But again, it's depending on the context. But the part that's not different is the co-creation of the curriculum.
That's great. Next question is for Taylor. How can we donate supplies to street nursing?
I am so glad you asked. The best way is just to email me at taylor.cafaro@ucsf.edu. So that's my name with a dot in the middle of it, at ucsf.edu. And our COVID lead, Janelle Silvis, has been completely slammed. So I'm trying to take some of the influx of folks. We've had an amazing turnout for donations. So there is definitely still need for more. Please email me. And I will either connect you with Janelle or take care of drop off, pickup. Happy to come to you and grab things. Thank you so much.
Great. And that email is in the chat. So check that out and please donate. This question is, I believe, also for you, Taylor. Has UCSF Nursing worked with SF Night Ministry?
You know, I'm not familiar with the San Francisco Night Ministry group. I know other cities have incredible night ministry programs. Megan Grant, one of the co-founders and co-directors, was working with a non-denominational night ministry project in Chicago, which is what brought her to the street-based nursing care with us. But please do email me and connect us if there is a group in San Francisco doing night ministry.
Okay, and just in, there's a question about does street nursing accept cash donations? And I assume if they are, how can they make those donations?
Yeah, we are. A few of us, not UC sponsored, are accepting cash donations through a GoFundMe. I will post that here in the chat. Thanks.
Great, thank you so much. Okay, this next question is for Orlando. How hesitant were the patients to be seen? Did it take some time to build trust?
It did, actually. Some of the I've been working with this population since, I want to say, 2010. I was a U.S. Fulbright scholar to Jamaica, and during that time, I volunteered as a nurse practitioner, and so I had already built relationship with the community and with many of these individuals. Some of which included going into the sewer system to provide services. So it's a long-standing relationship that I've sort of like cultivated over the years.
That's great. The next question, I believe, let's see, sorry, is for Carolina again. How did you address patient health information with shared group meetings in Mexico and the US?
Yeah, so that's an interesting, that always came up in every setting I went into. That was always a big concern, but apparently it's a bigger concern for us than it is for patients, at least the populations I've worked with. You do obviously confidentiality, you have agreements that they sign similar to HIPAA, but just acknowledging that group, information is going to be shared. And even in small rural communities in Chiapas where, they're really small towns, we were concerned about that, but it has been a non-issue. So I think people are much more, they're so isolated and alone that I think that the being in community is stronger than the fear of losing anonymity. In fact, losing anonymity is a good thing in most people's eyes.
Okay. And I apologize. I pronounced your name wrong, Carolina. I'm sorry.
It's okay.
I'm sorry. The next, and just to let you know that the GoFundMe has been posted on the chat. Let's see. This is for Taylor. If you identify a need for additional level of care, do you make referrals?
Yeah, I would say one of the biggest things we do is make referrals. And I think we do a lot of triaging, because there is sort of, the layperson's understanding of where to take a certain medical condition is going to be affected by how they're feeling about the medical condition. And we are able to provide advice on where to go, but also to link people with specific places where they can seek care at an appropriate level. We do a ton of primary care referring. And a lot of follow-up. Luckily, being at Lava Mae, we see the same people every week. And so we're able to do incredible amounts of follow-up that isn't possible otherwise, and we do a lot of referrals.
Okay. So we don't have any, I think we've hit all the questions for today, but I just want to remind everyone that the slides and recordings will be available after. And I did cover all of the questions, but I encourage all of the participants to look at the chat because there are countless comments and support of thanks and just great positive feedback there that please, you don't want to miss out on that. So with that, I'm going to turn it back over to Dean Gillis.
Thank you very much, Peter. And thank you to a big thank you to our team of presenters. When we originally imagined this program, we expected to be in Cole Hall in person. There's been a significant adjustment on the part of all participants to get this into a very crisp and concise format that we could share with you on Zoom today. For most of the time that we've been together, we've had well over 200 people on this Zoom. And I want to thank those of you who joined us as well. please enjoy the beginning of our special week of celebration of our most trusted profession. Our contributions from the School of Nursing are just the beginning. There's a whole week of events that are planned this week and going into next. And if I might, for those of you who are still with us, I would like to ask that you join us in thanking our presenters.
Thank
you.
you.
Thank you.
Thank you.
Thank you.
Thank you.
Salute.
Thank you.
Have a great
Yeah,
week.
that was
Fantastic.
amazing.